Thank you for joining us online for our Spine Surgery Institute pre-op education class. My name is Sarah Hewitt, a nurse at StoneCrest, and I'll be teaching your class today. We do have some objectives for today. I want to make sure you understand your procedure, what to expect during your hospital stay, the role of your coach, what physical and occupational therapy we'll be doing while you're here at the hospital, pain management, the expectations we have for you at home, the discharge planning, and a big purpose of this class is to ease your anxiety and answer any questions that you might have. My role as the care coordinator is to teach the pre-op education class that you guys are watching. I do daily rounds. I'm here Monday through Friday, so I'll be coming in to see you, check on you, make sure everything is going well. I'm your advocate, so I want to make sure that you're having a good experience. Each morning, I'll meet with your nurse, our case manager, and one of our therapists, and we'll chat about you, and we'll make sure we've got everything in place for you to go home. And then once you're at home, I'll call and check on you and make sure everything is going well. You'll be up on our 4th floor. It's our spine and joint unit. It's a dedicated unit. Our staff went through training so they know how to take care of patients who are having spine surgery. We also have a rehab room on the floor, and it has a tub shower combo. So if you have a tub shower where you have to step over that tub wall, that can be a little tricky after having spine surgery. So our occupational therapist will practice that with you. What's nice about the shower bench is it allows you to sit down, swing your legs over, scoot in, and then stand up for your shower. You may not have that endurance to stand up for your entire shower, so that seat might be nice in there for you. Also, we have a practice set of stairs that we'll practice with you, and we can mimic your home environment. We have handrails on both sides. You will be in private rooms, so no roommates while you're here at the hospital, but you are allowed to have your coach stay with you if you like. So a little bit of the spine anatomy. Your spine is made up of 33 vertebrae. 24 of those vertebrae are separated by the spongy disc. So I'm going to show you what that looks like. So this is the lumbar spine, and you've got a vertebrae, which is the bone. You've got your disc, vertebrae, disc. This is the front of your body. When you go to the back side of your body, you have this bone that sticks out here. This is called the spinous process. This is the bone you feel when you go down someone's spine. There's 2 little bones on each side of the spinous process, and those are called the lamina. And then what's right behind there is your spinal cord. And then these nerve roots right here branch off of the spinal cord, and they help everything work in your body. There are 7 cervical vertebrae, which are on your neck, 12 thoracic, which is your torso, and then 5 lumbar. And then the S1 is that triangular bone. Indications for needing spine surgery. First thing is degenerative disc disease. That is actually normal body age, wear and tear of your body. Your discs are typically hydrated. They're your shock absorber. And over time, wear and tear, the hydration leaves and those discs become fragile and they start collapsing. And they can start pushing on the nerves or your spinal cord. And when it's in your neck, it's going to cause lots of neck and shoulder blade pain, arm pain. When it's in your back, it's going to be causing that lower back pain and leg pain. This can lead to arthritis, disc herniation, or spinal stenosis. So in this picture, you'll see the disc herniation. At the picture on the left, you can see L3 disc space, L4 disc space, and then L5. The white you see running down is the spinal cord. And so everything is where it should be in there. When you look at the picture on the right-hand side between L5 and S1, you can see where that disc is bulging out and it's pushing on the spinal cord. Spinal stenosis is a narrowing of the spinal canal, and that can be due to bone spurs and or the herniated disc, and that causes a lot of pain, numbness, tingling, burning, weakness, and loss of muscle control. It can also cause you the inability to walk more than just short distances. So if you have to walk far distances, you may have to stop halfway before you get to your destination just to let that pain ease up. In the picture you're looking at, this is spinal stenosis, pretty significant between L4 and L5. It looks like that spinal cord is completely cut off. It's not, it's just so compressed you can't see it. Radiculopathy, that's just a fancy word for compression of the nerve or nerves. That comes with pain, numbness, tingling, weakness along the course of that nerve. The picture on the right-hand side, that's showing the herniated disc, and you can see it's pushing on the nerve, and then the picture on the left-hand side, that shows a couple different things. That is showing the bone spurs pushing on the nerve root, but then it's also showing where the lamina has some bone spurs underneath it where it's pushing on the spinal cord. So there's a little bit of spinal stenosis as well. Myelopathy is a functional disturbances of the spinal cord rather than the nerve. So what that's talking about is It's not always accompanied by pain because you don't always have nerve involvement, but usually do, so you're usually having some pain. This can come with tingling, weakness, bowel and bladder problems, lack of fine motor control and dexterity. So your handwriting might be going bad, you might be dropping things. You can also get headaches, and that's a lot of times when the cervical spine is involved. And then these electric shocks. When that spinal cord is getting pinched, you might get these electric shocks going down your arms or your legs. Spondylosis is a fancy word for arthritis of the spine. It happens a lot in the facet joints. So your facet joints are the joints right here, and these allow your spine to glide nice and smoothly along each other. They keep everything in line. So just like a knee, there's cartilage between those two joints, and over time, wear and tear, that cartilage can start wearing down and bone spurs form. So you can start to have some decrease in range of motion in your back. You might feel some grinding and crunching, and that can be due to those bone spurs on the facet joints. Spondylolisthesis. This is where the vertebrae slides forward over the bone below it. It's pretty common in the lumbar spine. It can be something that is slowly progressing or something that happens pretty quickly. You wake up one morning and you're in a lot of pain, and that can be due to that vertebrae that slides forward over the bone below it. And it happens a lot with lower back pain, or you can have a lot of lower back pain, numbness, tingling, and weakness down the legs. This is an MRI of the same person lying down at L3-L4. You can see the spinal cord's a little bit pinched, but on the right-hand side, when that person stands up, the L3 slides over the L4, further pinching off that spinal cord. So we have some goals for surgery. We want to get the pressure off the nerves, get the pressure off the spinal cord, and ultimately we want to lessen your pain and get you back doing the things you love to do. So in order to do that, we need to do some decompressing. So we do the laminectomy. So you've got your lamina here, and so we can shave that off. We can do a hemilaminectomy, which is just one side, or we can do a complete laminectomy, which is both sides. In the presentation, you can see on your screen, what it looks like. And what that will do is it's going to open that space up where your spinal cord is to get the pressure off. And the second procedure of decompression is foraminotomy. So I call this the rotor-rooter procedure. So where your nerve roots are coming out, there's a hole, and we can shave around that hole and get the pressure off the nerves. Also, we can do the facetectomy, so where your facet joints are, we'll shave those down, and that will get any bone spurs that are pushing into the spinal cord or the nerve roots. We can shave those down. We also need to remove your disc for most of your procedures for a fusion, and so for the cervical fusion, we would remove the entire disc. We go from the front of your neck. And for the lumbar surgery, depending on which approach you have, which we're going to talk about those in just a little bit, but we can go from the back side of your body to get to that disc space. You can also have a cervical laminoplasty, which this is done in the neck, and that hinges open that lamina, as you can see in the picture, and that's going to take the pressure off the spinal cord and keeping that stability of keeping the lamina on without removing it. We can also do something called a cervical disc replacement. There are some pretty strict restrictions on who can have the cervical disc replacement. You really need to be younger in age and have pretty good bone quality. But what the cervical disc replacement will do is it'll allow that neck to move without being fused. So you don't lose any mobility in your neck with the cervical disc replacement. So let's talk about spinal fusions. There's several different ways we can do spinal fusions. In the cervical area, we can do an anterior cervical fusion or a posterior cervical fusion. In the lumbar spine, we can do a TLIF, which is a transforaminal lumbar interbody fusion. We can do a minimally invasive TLIF, which is a minimally invasive transforaminal lumbar fusion. We can do an anterior lumbar fusion, a direct lateral interbody fusion, or we could do an SI joint fusion. When we talk about doing a spinal fusion, we're fusing two or more vertebrae together to become a solid piece of bone. We're going to take out the entire disc space and we're going to replace it with bone graft material and a spacer. You may have also heard the doctor call it a cage. We're talking about the same thing. Spacer almost makes a little bit more sense. We're going to fill the disc space with something else to restore the height. There's different types of bone grafts we can use, and depending on your type of surgery, depends on what we use. And I'll go through that when we go through all the surgeries. but we can use synthetic bone, we can use your own bone, and we can use some donor bone. Also, the hardware we typically use titanium, and then also you may have the screws and rods and plates, and all those are also made out of titanium. All the hardware we put in you is MRI safe, so if you do need an MRI in the future, you can definitely have one. So let's talk about the cervical fusion first, called an ACDF. The cervical fusion is in your neck, and this is considered a 2-level fusion, meaning we're taking out 2 of the discs and we're replacing it with the spacer. So the spacers will go inside there. Inside, and you can see on your screen, there's like a little hole, and we're going to pack some bone graft material in that. And the type of material we use for a cervical fusion is synthetic bone. We do have to secure the bones with another piece of hardware, because if we didn't, you would never fuse, because it's not solid bone yet. It takes about 3 to 6 months for bone to start to grow. So for a cervical fusion, we are going to put a plate on and screws, usually 2 screws at each vertebrae. And so this is the cervical fusion, the anterior cervical fusion. The next fusion that we do is the posterior cervical fusion. And I don't have a model of that, but you'll see a picture on your screen. But basically what that is, it's like a miniature version of a lumbar fusion. You've got screws and rods at each level. And usually when your doctor wants to do the posterior cervical fusion is because they need some more stability in the back of your neck, and also sometimes they need to do a laminectomy where you may have some bone spurs forming underneath that lamina and pushing into the spinal cord. In the picture that you see, you'll see a cervical fusion, and that cervical fusion, you see the anterior and the posterior approach. What I like for you to see though is at the C5 and C6 level, that is a successful fusion. It looks like that bone has completely fused together. And that's what your surgeon is looking for when they have you follow up at your follow-up appointments when they do the x-rays. They're looking for that bone growth. The next fusion is the lumbar fusion. This is the T-lift. And so the difference between a T-lift and a minimally invasive T-lift is actually just the incision. So for the minimally invasive T-lift, you're going to have 2 small incisions on each side of your vertebrae, about 1 inch to 1.5 inches long. And for the traditional lumbar fusion, you're going to have a longer incision. And it just depends on how many levels we do, depends on how many inches it is. But everything inside is exactly the same. So this is a 1-level lumbar fusion. This is the spacer, the cage that goes inside, and these are the screws and rods we put on the backside. Just like with the cervical fusion, it does take 3 to 6 months for that bone to grow, so we have to secure it with something. The type of bone graft we use is synthetic bone. We also use your own bone. So people often wonder, where do we get your own bone? Well, the lamina and maybe the spinous process that we remove, we just keep that bone and we grind it up and we mix it all together with that synthetic bone. So we'll pack also the disc space with some more bone graft material, and so then this will become a solid piece of bone. People also wonder if the hardware will ever be removed, and hopefully not. We hope that this will stay with you and we don't have to go back in and take it out. If you needed to have more surgery on your lumbar spine or cervical spine, there is a chance we could remove the hardware at that point. The next picture is a picture of a successful lumbar fusion on the left-hand side between L5 and S1. There is a successful fusion. Also in that picture, you can see that the spacers have markers on them, and so that can be seen if you have to have an x-ray in the future. The picture on the right-hand side shows you where the fusion is starting to form between L3 and L5, but it's just not quite fused yet. So it's getting there. So it's a pretty new fusion. So the next type of fusion is an ALIF, an anterior lateral interbody fusion. This is where we go through the front of your body. We make either a horizontal incision or a lateral incision. It just depends on your anatomy and where the fusion is going to take place. You will actually have 2 surgeons. You will have a vascular general surgeon who will open up the incision for your doctor, and then your actual doctor will do your spine surgery. So this is what your spacer cage will look like. It pretty much fills the entire disc space. It is hollow, just like all the other ones, and we will put bone graft material in here. We typically will use a synthetic bone. We do have to secure it, just like the other ones, and we could use a couple different approaches. Spine surgery, there's many different ways to accomplish the same thing. It just depends on, your issues, and the doctor. So this first one is where there's a plate, but it's embedded, so you can't feel it on the outside, but there's screws that screw the spacer into the vertebrae. The one down here is more of an external plate, similar to the ACDF where it's on the front side. But these are two different types of anterior lumbar fusions that we could do. The next lumbar fusion is called a DLIF, and it's called a direct lateral interbody fusion. And that's where we go typically from the left-hand side. This is the shape of the spacer that we use, and it's inserted from the side. We use synthetic bone for this one as well. We pack that full of synthetic bone and we put it in. Sometimes your doctor can put a little plate on the side, similar to the ACDF where there's a little plate, or they can do another procedure on top of that and do the screws and the rods like you would have for the T-lift, but you're not going to have the cage inserted from the back side. You will have it inserted from the side. But sometimes instead of putting the plate on the side, they will decide to go ahead and put screws and rods on the back side. The other part your doctor might decide to do is called a posterior lateral arthrodesis, and that's where they lay bone graft over where the screws and rods might be. Sometimes they decide to do this and you don't have screws and rods back here, but what they do is they rough up the bone around that area and they lay bone graft material there. And that bone graft material will also become a solid piece of bone and become hard. And it's just to give your spine some more stability back there as well. The next type of fusion is an SI joint fusion, and that's where your S1, your sacrum, will be fused to your pelvic bone. And there's 3 little dowels that they will use, and that will stabilize that SI joint area, and it will also help with some of that pain you might be experiencing. So some risk factors. With any type of surgery, you're at risk for something. So these are the ones we're going to focus on. Spinal cord and nerve injury. As the doctor's cleaning up around everything, there's always a tiny chance that they could nick a nerve or nick the spinal cord. So that's always a risk factor. But to ease your anxiety a little bit, before you even go back for surgery, you are going to meet the neuromonitoring tech. And they are going to put these sticky wires on you. They'll put them on your wrist and they'll put them down on your ankles. So through the entire surgical period, they will have full visualization of your nerves. So if there's any, they lose connectivity or they're getting a little too close to the nerves, they'll know immediately if anything happens. Also, in addition to these sticky wires, they will put little tiny baby needles, kind of like an acupuncture needle in your head. They can put some in your hands and down on your legs. And the only reason why I want to mention that is when you wake up, you may see little drops of blood in your head or blood on your legs. And it's not anything that went wrong. It's just those little tiny baby needles can bleed a little bit. Also, vascular injury. Your blood vessels are running right alongside, where those nerve roots are coming out and, down the front of your body. And so they're very careful when they are cleaning everything out that they are not getting close to those blood vessels. Also, non-union. So there's several risk factors for not fusing. So non-union is we want bone to grow between those vertebrae that we are fusing. And there's several risk factors why that may not happen. So the number one thing is smoking. Smoking is super important to quit because that can slow down the healing significantly. Smoking and nicotine softens bones. So the soft bones plus try to grow bone, they don't mix very well together. And then also it can constrict blood vessels. So the oxygen-rich blood isn't getting to that new bone to help it grow. Obesity, this is big for the lumbar spine. Your body takes on a lot of pressure on that lumbar spine. So if you have extra weight that you probably added on because you haven't been able to move because you've been hurting, that extra weight can slow down that healing of the fusion. Osteoporosis. So osteoporosis is your bones aren't as dense. It's more wholly like Swiss cheese, if you can think of that. So it's going to take longer for that bone to grow between the vertebrae. Diabetes you don't unfortunately have control over, but it's where you have too much sugar in your body, and that overload of sugar can slow down the healing of your fusion. And then malnutrition, so we want you to eat a well-balanced diet. Lots of protein and lots of vegetables are going to help with your wound healing. Our goal for you, if you are a smoker, is to try to quit smoking at least a week before your surgery and then at least 6 weeks after your surgery to help with that fusion. If your doctor is worried about your bone growing, they may order something called a bone stimulator that will be delivered to your house after your surgery is over with, and that's going to stimulate that bone to grow a little bit faster than it would on its own. Adjacent segment collapse. So before we fuse your vertebrae together, each vertebrae is moving individually. There's a disc between each one. But when we start fusing your vertebrae together, now that whole section is going to function as one big bone. So over time, wear and tear, the disc above or the disc below, the fusion can start taking on that extra pressure, and those other discs can start going bad. So just because you're having a fusion, that doesn't mean that you're going to have another one in a year, 5 years, or even 10 years. But just know there's a risk once you start fusing a section of your vertebrae, those other discs, depending on their condition, can start going bad. Dural tear, your spinal cord is surrounded by a fluid-filled sac called the dura. So remember the lamina we talked about. Behind the lamina there can form some bone spurs, and over time wear and tear of those bone spurs wearing out the dura, the protective fluid-filled sac that protects the spinal cord. When the doctor is going in there and cleaning everything out, that dura is almost like tissue paper and it can tear. And so the surgeon will repair it, because if they don't, then you would have a pretty bad headache, because you need that spinal fluid to get up to your head and everything and keep everything protected. So if there's a leak, you don't have enough spinal fluid to get up to your head, and that's what typically would cause the headache. So you will be notified if you do have a dural tear, because we will have you on bed rest. We will have you pretty much laying flat until the next morning. Depends on how big the tear is, depends on how long you might be on bed rest for. And so we have you on bed rest because we want to take the pressure off where that tear was. And that fluid will naturally go back and forth, and you should not have a headache. And so that next morning, we will gradually sit you up and we'll ask you if you're having a headache. And if you are, then we're going to lay you back flat. If not, we're going to keep moving you up, and then we'll let therapy start working with you that next morning or whenever your bed rest ends. But they do repair it. They'll either suture up the tear or they'll put like a patch over it. Just depends on how big the tear is. And it takes, depending on how much fluid you lost, it could take a couple days to build up that spinal fluid. But we do encourage you to drink lots of fluids. Caffeine can kind of help with some of those headache symptoms as well. And the last thing on there is infection. We don't expect you to get an infection, but we want you to know what to look for. So some of the symptoms of an infection are fever, increased pain, swelling, and drainage at the incision site. And you're going to have some drainage, but we don't want that drainage to start changing color. So a watery blade drainage is okay. If that drainage starts to change to yellow, green, cloudy, red, hot, angry incision, we do not want to see that. So if you start seeing that, you're calling your surgeon right away. We want to make sure you wash your hands before you touch your incision. Don't let your pets lick your incision, get near your incision. That's a big one for you guys with your neck surgery, because pets like to lick your face and your neck. So keep them away from your incision, because it's not clean. Also, we don't like the pets to sleep in the bed with you. So if at all possible, don't let your pets sleep in the bed with you. And then we ourselves are covered with bacteria, and we're constantly shedding our skin cells. So we want you to change your bed sheets at least once a week until your incision is completely healed. So bathing and incision care after your surgery. So you are allowed to shower after surgery pretty quickly, about 2 to 3 days, 1 to 2 days. It just depends on where your incision is. So you'll be notified by your surgeon on when you can get your incision wet. We allow you to shower, but we don't want you to take a bath. We don't want that incision to be submerged underwater until it's completely healed. You can gently wash your incision with soap and water. You can pat dry. We don't want you to put any ointments or any peroxide on your incisions until it's completely healed. And actually, you shouldn't need anything on there at that point. But no peroxide, no ointments on your incision. You have glue that's sealing your incision. Sometimes you'll also have steri-strips, and the steri-strips and the glue will fall off on their own. And if you put any ointments or peroxide on there, it's going to prematurely take that glue off. Don't scrub your incision. You can gently wash it with that soap and water. There's no special soap that you have to use, just a lot of soap with perfumes and lotions. Probably want to stay away from those. Occasionally, your doctor could use sutures or staples, and that just depends on your incision. If it's really big or if you've had previous surgeries before, a lot of times scar tissue does not stay together very good with just glue, so they may opt to do staples or sutures. Also, after your first shower at home, we want you to go ahead and put a nice fresh dressing over your incision. Even if you don't think it's draining, you're going to be at home, you're going to be moving more. So after that first shower, put a fresh dressing over the incision, and then you're going to change that bandage, the dressing, every day until you don't see any more drainage on there. You want that dressing to come off clean. So every day until there's no more drainage, fresh bandage. Average length of time for surgery. So this is just an average. So if you have a multi-level fusion or a multi-level surgery, it could take a little bit longer, but this is kind of the average of what each procedure takes. So an SI joint fusion takes approximately 40 minutes. A cervical disc replacement takes approximately 45 minutes. A micro discectomy, which we really didn't talk about earlier, that's where they shave off part of the disc, not the entire disc. So when you need a lumbar fusion or a cervical fusion, that whole disc is coming out. But if just part of the disc is bad, then we can do a micro discectomy. And we can only do a micro discectomy on a lumbar vertebrae or lumbar spine, that lumbar disc. And so that will take about 50 minutes, just depends on how many levels we're doing. An ACDF takes about an hour. A lumbar laminectomy takes an hour. A posterior cervical fusion, where we go from the back to fuse the cervical spine, takes about an hour and a half. The ALIF is about an hour to an hour and a half. The DLIF is about an hour to an hour and a half. The minimally invasive TLIF takes about 2 hours, and the traditional TLIF takes about 2 to 2.5 hours. Now, this is typically the time that it takes for the surgery. You will likely be in the operating room about 40 minutes to 60 minutes longer, getting you prepped for surgery, getting you off to sleep, and then waking you up for surgery. So average length of stay, those of you having an ACDF or cervical disc replacement, you could go home that same day or just stay one night at the hospital. Cervical laminoplasty, you'll stay about 1 to 2 nights. Lumbar laminectomy, usually just overnight stay. Microdiscectomy, depending also, usually it's a 1-night stay. Unless it's pretty, minimally invasive, then you'll get to go home that same day. SI joint fusion, that could also be same day to 1-night stay. Posterior cervical fusion, 2 to 3 nights. Minimally invasive lumbar fusion, usually that could be outpatient or 1 night. And then the DLIF is 1 to 2 nights. And the lumbar fusion, the ALIF and the traditional TLIF is 2 to 3 nights. So spine healing time. So if you're just having a laminectomy, it's basically healing of the incision. We still want you to be cautious for about 6 weeks after surgery. A microdiscectomy, we want you to be cautious for about 6 weeks. Lumbar fusion and a cervical fusion, about a good 3 to 6 months. That's when it takes for that bone to start growing. And so we want you to be on those strict precautions for a good 3 months. As you follow up with your surgeon, they will start lifting some of those precautions, but usually the big heavy duty stuff is a good 3 months before they let you start going back to doing those things. And even at 3 to 6 months, you'll probably still be on some sort of lifting restriction. And occasionally it can take up to a complete year for that bone to grow between those 2 vertebrae. Returning back to work, this is a big question between you and your surgeon. It just depends on what you go back doing. So light duty is about 2 to 4 weeks. Heavy duty is a good 3 to 4 months. And no driving until you get the A-OK to drive from the surgeon. So rule of thumb for driving is you're off your pain medicine during the day, you've got good hand strength, good feet strength, and feel safe to drive. And of course, don't try to go back to work too soon without getting permission from your surgeon. So a few things to prepare you for surgery. We want you to use your guidebook. You will all be provided with a guidebook. That guidebook is full of frequently asked questions. It's split up into 3 sections, getting the house prepared before surgery, during your hospital stay, and then going home. We do ask that you bring that guidebook with you to the hospital and to your doctor's appointments. It's nothing that we need to see, but throughout your recovery and stuff, it's nice to have that front pocket and you can add stuff to it as we give it to you so it all stays in one spot. So we want you to prepare your home. So a few things to prepare your home. We want a good supportive chair, something with armrests so you're able to push yourself off and on the furniture. We like you to put away those area rugs. They can become a tripping hazard. Some of your surgeries will require you to go home with a walker, and we don't want those walker wheels getting stuck on the rugs. Also, shop ahead, have some easy to prepare meals. We don't want you in the kitchen for long periods of time on your feet trying to cook. Line of support, especially if you live alone. We like someone to be home with you for at least that first week at home. Arrange for someone to help care for your pets. One of the big things is your cat box. It sits really low, so that's one thing you're not allowed to do after lumbar surgery is bend over at the waist. So you'll definitely need help with that, or get it set up on, a higher surface so you don't have to bend over to clean the cat box. Also, we encourage you to go for walks, but we don't want you to hold the leash while you're walking a dog. So if your animal does need to be walked, definitely have help with that. Also, those frequently used items, go ahead and lift those up to the countertop level. Coaches can stay with you at the hospital if you want them to. Your coach can be a family member or a friend. They're going to get a coach button, and we encourage them to wear this coach button while you're here at the hospital. That just lets everybody know that that's your coach, the person that's going to be home with you. So they can watch your therapy sessions while you're here at the hospital, and then they'll provide comfort and motivation when you get home. And both you and your coach will gain the confidence that your coach is going to be able to take care of you at home. We are a non-smoking facility. For you guys having surgery, you will get breakfast, lunch, and dinner every day of the week. But for our visitors, we are closed in the evening time. So we're open for breakfast and lunch Monday through Friday. We're closed every day for dinner, and then we are closed every day on the weekend, or for all meals on the weekend. That being said, if you do have a family member who's here, they don't want to leave, there are several options near the hospital that deliver, and then also they can purchase a meal ticket at the information desk, and that meal ticket will allow your family member to order off the menu with you, so both your meals will come up at the same time. Daily newsletters, so I call this kind of the cliff notes to come into class. This is what I like to go over with you when I come and see you after your surgery, and so we'll go through all these newsletters. It's basically the highlights of what to expect that day and expectations. So daily homework, we're going to talk a lot about pain management in just a little bit, so we're going to skip that one on the list. Ankle pumps, that's moving your ankles up and down. That's going to help with circulation. We like for you to do 20 to 30 of those every half an hour while awake. That's going to help with circulation, help prevent blood clots while you're resting. Also, nerve glides. This is going to help stretch those nerves out. It's when you're in the seated position, you're going to kick your leg out straight, get your knee straight, and get that leg up as high as you can. That's going to stretch those nerves. We do like for you to do 50 of those throughout the day. We don't want you to do all 50 at once. Do about 5 sets of 10 throughout the day. We also like for you to do walking. And with the walking, you want to gradually increase your distance as comfort allows. We want you to start out doing maybe 3 to 5 minutes at a time and then gradually build on that. Our goal for you by 6 weeks is to be able to walk 1 mile. And that 1 mile is not without stopping. So if you didn't walk a mile without stopping ever before, we don't expect you to do that after surgery. So it's all those walking sessions throughout the day to equal your mile. Now, if you are doing really good with a mile, you can go 2 miles, but we don't want you to exceed 2 miles in the first 6 weeks. Your surgeon will let you know when you can start increasing that activity. Also, we want you getting up and moving about every hour at home. So, change positions. If you're sitting down, 45 minutes to an hour, get up, walk around the house a little bit. If you were comfortable sitting, go sit for another 45 minutes to an hour. But then after that, you need to go lay down and change positions. We do like you out of bed for all your meals. It's not because we're being mean, but the more you move, the better. As those muscles want to heal and everything around the incision, everything wants to get stiff and tight. So we do want you sitting up straight. Also, for those of you having the cervical fusion, we want to make sure you're sitting up good, straight, and tall because it can be a little bit difficulty to swallow. Sleeping position and spine precautions. So to get in and out of bed, we do want you to do something called log rolling. And this is in your guidebook, but if you're on your back, you roll to your side, and then your legs kick off the bed, and then you sit up. That's going to avoid that twisting motion and pressure you might be putting on the upper chest to try to just sit right up. So do your log rolling to get up. Our therapist will practice that with you. As far as sleeping positions, you're allowed to sleep on your back and you're allowed to sleep on your side. So if you're a side sleeper, we do like a pillow between your knees and then hugging a pillow in front. That's going to help keep your spine in line. Some people like to also put a pillow behind their back to support it. If you are a stomach sleeper, we don't want you sleeping on your stomach. So you're allowed to sleep on your back and your side, but no stomach sleeping. But if you are a stomach sleeper, there's a little trick you can do is Sleeping on your side, have that pillow in front of you. You can kind of side stomach, but we don't want you sleeping where your stomach and face is in the pillow and on the bed, because that puts your spine in an abnormal curvature. Also, sleeping on your back, you can put some pillows up underneath your knees, put a couple pillows up underneath your head, and that will raise those legs up and take some of that pressure, kind of put your back in kind of a neutral position. Also, if you have one of the mechanical beds at home, you can press like a zero gravity button and that will get you in that position. But if you don't have a mechanical bed, pillows will get you comfortable. Also, if you are cervical fusion, you may feel more comfortable sitting more elevated with your head up. You may not feel comfortable completely laying flat. So sleeping up in a recliner might be more comfortable for the first several days. And then also propping your arms up on some pillows, taking that pressure off your shoulder blades and everything is going to take some of that pressure off. So, propping your arms up like this. Also, for deep breathing, we're going to go over the incentive spirometer in just a couple minutes. But that incentive spirometer is going to help with that good deep breathing. And we also want you to cough and deep breathe throughout the day as well. And we'll go over that. And then also your daily household chores and tasks. So your coach gets to be the boss of you for a little bit, but they get to pick up the extra slack in the house. So you get out of doing the dishes, the laundry, and the vacuuming for a little while. So incentive pathway. So basically what this is the discharge goals before you get to go home. So we'll be checking these off throughout your hospital stay. There's a dry erase board in your room that we'll be marking on. We do want you to stop some medicines that can increase your bleeding. So any of those anti-inflammatory medicines, we want you to stop 7 days before your surgery. So medicines like aspirin, Aleve, Motrin, Mobic, fish oil, vitamin E, those can all thin your blood. So we want you to stop those. Now, if you're on any prescription blood thinners for like atrial fibrillation, or you've had a blood clot in the past, you've got a stent in your heart, those medications, we want to make sure that your primary care, your prescribing physician who has prescribed those medicines have cleared you for surgery and stop those. Usually it's about 5 days before surgery, but you need to get permission from that prescribing physician. You'll go to pre-admission testing before surgery. At that pre-admission testing appointment, we'll go over your full health history. We want to know all your medications, prescription and over-the-counter medicines. We'll be doing some blood work. We'll do an EKG, typically if you're over the age of 50. And then we'll have you sit down with our anesthesiologist and go over your health history with them. So if there's any issues with anesthesia in the past, it's the perfect time to talk to them about that. So there's a few things we want you to bring with you for surgery. The first thing is a positive winning attitude. We want you excited about having your surgery. I know having spine surgery is probably not in the bucket list of items to accomplish in your lifetime, but there's probably still some things in that bucket that you want to accomplish. So we want you to get better and do those things. Also, bring your guidebook with you. We've already talked about that. That way you have it, at the hospital for a nice reference. Your insurance card and ID. You might need that when you pick up your prescriptions. Of course, when you get registered at pre-admission testing, we'll get a copy of that. So we don't require it, but just in case you need it for anything else, it is nice to have your coach or a friend hold on to that for you. Also, your CPAP and BiPAP machine. If you have sleep apnea, you're going to be in a deeper sleep when you do get to sleep. And so we definitely want you to bring that machine with you. Give it a little cleaning up, check the tubing, check the filter, check the wiring. Our biomed technician will take a look at it to make sure that it's safe to use while you're here at the hospital. Also, if you have a favorite pillow, you can't sleep without, bring that pillow with you to the hospital. We do like you to stick it in a pillowcase other than white. That way it will stand out so you don't forget your pillow. Your hygiene items like your toothbrush, deodorant, anything you use on a daily basis, you're more than welcome to bring that, but you don't have to. We have all that stuff available here at the hospital as well. Loose fitting, comfortable clothes. We actually want you out of your hospital gown. We want you in some nice, comfy clothes that you typically lounge around the house in. We are going to be having you up and getting out in the hallway, so we like you to be in some comfortable clothes. Those comfortable walking shoes, so even if you have lace-up shoes, it's okay. Bring those shoes that you're comfortable walking in. Of course, slip-on shoes are going to be a little bit easier to put on. We don't like the Crocs or the flip-flops because they can become a tripping hazard while you're here at the hospital and at home as well. A back brace. If you were given a back brace by your surgeon, we want you to bring that with you to the hospital. If you did not get one, no worries. If your surgeon does want you to get one, they will order it after your surgery. We want you to leave all your valuables at home. We don't want you to bring anything valuable, no medications, anything like that, cash, all that. We want you to leave at home. If there are any medications that we don't carry here at the hospital, then we will let you know and we'll have your family or friend bring that in. Our pharmacy will check it and we'll lock it up for you. Leave all your valuables in the car in the morning. You will get here a couple hours before surgery. Your surgery can be a couple hours, and then recovery room is a couple hours. So we don't want your family, your coach, your friend dragging your stuff all over the hospital until you get out of surgery. Just leave it in the car and they can grab that when you get your room assignment after surgery. So before surgery, we want you to pre-medicate with some Tylenol. Studies have shown that getting an increase in Tylenol in your system will help with that post-operative pain. And so what we like for you to do is do 2 extra strength Tylenols, which is 1,000 milligrams. So you'll take 1,000 milligrams 3 times a day, 4 days leading up to your surgery. Now, if you take any prescription medicine like a Percocet or a Norco or an Ultracet, those medicines have the acetaminophen in it. In addition to the narcotic, it has Tylenol. So Tylenol and acetaminophen is the same thing. So if you currently take a medication that has the acetaminophen in it, we do not want you to take any additional Tylenol in this case. So just stick with what you normally take. You can only take that extra Tylenol if you're not already on any medicine. If you test positive for MRSA or MSSA, your surgeon's office will call in a special ointment called mupirocin, and it's an antibiotic ointment, and it's going to kill that bacteria that can live in your nose. So we like to prevent any kind of infection in your body before surgery. So you will do that twice a day in your nostrils, 5 days leading up to your surgery. It is important to make sure you get that last dose the night before your surgery. So if for some reason you couldn't complete the full 5 days of the mupirocin, then definitely let us know so we can continue that while you're here at the hospital. Also, we do ask that you bring that mupirocin tube with you into the hospital that morning so we can verify that you've been using it. The night before surgery, we want you to wash your body just as normal. Wash your hair, wash your face, just wash your body like normal. After you get out of the shower, you're going to wait a good hour. When you go through pre-admission testing, they're going to give you some special wipes, and they're called CHG wipes, and they will go on your body, and there's a diagram I'll go over on the next screen, but there's a special cleansing solution that's going to kill all that bacteria on your skin. You don't want to put these on right after you take a shower or shave, because all those skin pores are going to be open, and this solution can irritate those skin pores. So no shaving, and don't put these on right after you shower. You want to go ahead and have some clean bed sheets on the bed, because you're going to disinfect your entire body, so might as well get that bed clean so you get into a clean bed, and then you're going to be good for a week after your surgery. The next screen is a diagram of how you put the wipes on. It doesn't matter what order you go in as long as you use that particular or that wipe for that particular body part. So one wipe will be your neck, shoulders, and chest. The next wipe will be both your arms and hands. A third wipe will be your abdomen and groin area. Your private areas, your face, you're not going to use these wipes on there. The fourth wipe will be your right leg, fifth wipe left leg, and then the sixth wipe is really the only wipe you need to go in order. You need to go from the back of your neck down to your buttocks. That one you will need some assistance with because you can't get to that area very good. Now, the first inactive ingredient in these wipes is aloe. So if you ever put aloe on your skin, you know how that makes you feel sticky and yucky. So you're going to be tempted to want to wipe it off, but don't just let it air dry. It will either leave like a smooth feeling on your skin or kind of like a residue, but just know that it's killing all that bacteria on your skin. As far as applying the wipes, you can go in a circular motion or you can go in up and down motion. Give it a little bit of friction, but don't scrub too hard because that can also irritate your skin. Enhanced Surgical Recovery, also known as ESR, is a research-based program that we follow, and basically what it is several little things have been changed throughout your surgical experience to make everything better in a positive manner. So the night before and morning of surgery, we don't want you to eat anything after midnight, but you are allowed to have clear liquids 3 hours prior to your surgery. Before, it was nothing to eat or drink after midnight, but part of the ESR program, they found that allowing you to have something to drink keeps you hydrated, and it helps, with recovery after surgery. Also, you can brush your teeth if you want to, and then any medications that anesthesia may have talked to you about taking that morning of your surgery, you can take that with a sip of water. For those of you having the ALIF procedure, where we're going to go in the front of your abdomen, you will be on a clear liquid diet the day prior to your surgery, and you will start a bowel prep to clean out all those bowels at some point the day prior to surgery to clean everything out before surgery. We do want you to drink that carbohydrate rich beverage that you may have gotten at pre-admission testing. And so it looks like this. It's Ensure, but it's not the Ensure you would get on over the counter. It's a clear beverage. And this is going to help those cells with nutrients during surgery. It's going to keep you hydrated. So it's full of carbohydrates and electrolytes. If for some reason you do not get this while you're here during pre-admission testing, there's a reason. You might be a diabetic. So they don't like to give you this because it can elevate your sugar. And so if they don't, you can just do like a sugar-free Gatorade or some sort of hydration to give you some nutrients, that as long as it's clear that morning before surgery. We do like you to have this completed 3 hours prior to surgery. We do like for you to get a good night's rest because you're going to be getting up with therapy that afternoon. Remove any kind of jewelry, any body piercings. Anything can cause like a spark and burn you, and we don't want that to happen during the surgery. We don't like you to wear deodorant. The chemicals in the deodorant they're not compatible with the CHG wash that we have you use. The day of surgery, do not take a shower. The CHG wipes are still working on your skin to kill all that bacteria, so we do not want you to shower that morning. You'll check in at the registration desk just like you do for pre-admission testing. We'll get you all checked in, complete that process. We'll bring you back to the waiting area. And then we'll come and get you, bring you to the same day surgery area. We'll have your coach stay in the waiting room until we get you prepped and ready. But as soon as we get you prepped and ready, we'll let them come and sit with you. So as we're getting you ready in the same day surgery area, we'll have you change into a hospital gown. We're going to have you put those CHG wipes on all over again. We're going to have you apply those. We're also going to add a nasal antiseptic. It's povidone iodine, and it will go in your nose. And it's going to kill all that bacteria as well in your nose, regardless if you tested positive for MRSA or MSSA. During same-day surgery, we're going to do a head-to-toe assessment. We're going to make sure that you're still feeling well for surgery. We're going to apply TEDs and SCDs. So these are TED hose. You may have seen these before. They're compression stockings, so these are knee-high. They'll go from your toes up to your knee. Depending on how long your legs are, it could go up behind your knee or it could just go right below your knee. The biggest thing with these is we want to check for wrinkles. Sometimes it wants to wrinkle behind the knee and around the ankle. And if that happens, that's cutting into your circulation and it defeats the purpose of wearing them. The purpose of wearing these are to help prevent those blood clots while you're here at the hospital. Once you go home, as long as you're getting up, you're walking, you're moving around, you don't have to wear the TED hose. But while you're here at the hospital, we do like for you to wear them. Also, they're not one size fits all, so let us know if they're too tight, cutting off your circulation, or on the other hand, they're not tight enough and they don't feel like you have anything on. We want them to be snug, but not so snug where they're cutting off your circulation. But like I said, you will wear these during your hospital stay, and as long as you're getting up, walking, and moving around at home, you do not need to wear them. But keep them, put them in your sock drawer, because if you go on long car trips or plane rides, it's good to wear these. Also, in addition to the TED hose to help with circulation, you will have these little compression sleeves called SCDs, sequential compression devices, and they will Velcro around your calves. And they will hook up to a machine at the end of your bed. They'll squeeze one calf and then the other, and it's going to help with that circulation. We do like for you to wear these while you're in the bed. You will get an IV started for your procedure. Of course, you don't want to be awake for surgery. We'll give you any of that preoperative medication before your surgery that your surgeon or doctor has ordered for you. You will get an IV antibiotic. Usually it's just an antibiotic before surgery, and then you usually don't need any antibiotics after surgery. We will be asking you the same questions over and over each person that you see. Who's your doctor, your birthday, your name, anything like that. It's not because we don't know. We just want to make sure we're all still on the same page. You will see the anesthesiologist may or may not be the same anesthesiologist you saw before surgery and pre-admission testing, but they're there to answer any last minute questions. And then you will see your surgeon before surgery, and they're going to mark your surgical site. So again, another safety measure while you're in the operating room that we're operating on the correct body parts. During and after surgery, your coach will go back out into the waiting room. While they're out there, they'll get updates throughout your procedure. So when surgery is getting started, each hour that you're in there, and as surgery is wrapping up. Wi-Fi is available, so you can let your family know they can hook up to our Wi-Fi, bring something to keep them occupied during your surgery, because as you can see, some of your surgeries are a little bit on the lengthier side. You will be given a passcode when you go to pre-admission testing. That passcode is a 4-digit code. Give that to anybody you want information about you. They will need that code before we will give them any information. If you lose that code, let us know that morning so we can give you that code again. Recovery room, also known as PACU, that's where you'll wake up after surgery. You'll be on a hospital bed, and you'll be in recovery room about 1 to 2 hours. It just depends on how quickly you're waking up. We'll be monitoring your vital signs pretty frequently in the recovery room, and the vital signs are checking your blood pressure, your heart rate, your oxygen, making sure you're waking up good. When you arrive to our spine and ortho floor, you'll get vital signs on admission to your room, then hourly times 3, and then every 4 hours we will be in there monitoring your vital signs. We'll do a neuromuscular assessment. We'll have you squeeze our hands. We're going to have you move your feet. We want to make sure everything is waking up well after surgery. We're going to get your pain controlled down to a tolerable level. Just know we're not going to be able to take 100% of your pain away after surgery, immediately after surgery. Could have a little bit of a sore throat from the breathing tube. Your coach is kept up to date during the recovery room time. They cannot see you in the recovery room. Once you get out of the recovery room, they will meet you upstairs in your room. And this is the time that your room number will be assigned. So how are you going to be feeling? You're going to have a decrease in energy level. Your body's using a lot of energy to heal, so it's important to balance your rest with activity. You may want to limit those visitors, especially while you're at the hospital and then when you get home, because you need to get your rest when you can. Anesthesia may take a few days to get out of your system, so you may remember little to none of even being in the hospital, and for even a couple days after surgery. You want to begin with light foods for your first meal. Your stomach is still waking up from anesthesia, so you don't want to put anything real heavy on your stomach. Your appetite may take a few days to get back to normal, so you may want to try to force yourself to eat a little bit because you need all those nutrients to heal. Also, make sure you're staying plenty hydrated and drinking those fluids. For those of you having cervical fusions, one of the hard parts for you is you're going to have a little bit of a sore throat, difficulty swallowing, some hoarseness. That's all to be expected after surgery. So you're going to start with some soft foods. You're going to do liquids a lot as well. What I suggest is anything you try, you're going to take small bites, chew it up really good before you swallow. And then also, you may need to take your pills and swallow them in a applesauce or pudding just to coat them, because they can be a little bit difficult. They might get stuck. So things getting stuck in your throat is not going to be uncommon at first. You may feel like you're swallowing over a little speed bump. So with surgery, just the trauma of the surgery, because it's going to be a horizontal incision on your neck, it's going to follow a little skin fold you've got. So scarring should be minimal, but you're going to have some swelling there. A little bit of blood can pool up underneath the skin. And so that's going to feel like a little speed bump you're swallowing over. So if that happens, a little trick is to take a sip of water, turn your head down and to the right, and swallow. That is going to kind of stretch the esophagus and help that food go down. You may have to do that a couple times, but usually it does the trick. But if that keeps happening, you probably want to avoid that type of food you're eating. Usually tough meats like steak and stuff, fluffy breads, typically don't like to go down very good right after your surgery. So urinary catheter and drain. So you may not have a urinary catheter. That's a catheter that goes into your bladder and helps drain your urine during surgery. You may not have that, but if you do, your surgeon typically will have it be removed in the recovery room. If not, it'll be removed that next morning typically after your surgery. So you may or may not have a drain. So those of you who are having a larger incision, so for the incision on the back side, so like the open T-lift, you will have a drain called a hemovac drain. I'll go over that in just a minute. The ACDF will have a drain. Sometimes you do, sometimes you don't, but it'll be a drain on the front of your neck with a JP drain. And then if you're having the incision on the front or an incision on your left side, the A-lift or the D-lift, usually you do not have any drains with that procedure. And then also the minimally invasive lumbar fusion, no drain. So let me show you what the drains look like. So this is the hemovac drain. There is a small little tubing that will go inserted in your back, and it hooks up to this. And so as this fills up with your drainage, it will expand. And so if you see this fully expanded on the side of you, then we'll need to know so we can make sure we're emptying it. We'll be checking it throughout the day, but if it's completely full, it could have gotten disconnected, that's why it's expanded. Please let us know so we can come and check it. The other type of drain is the JP drain. We use this a lot for the cervical fusions on the front. And so it's like a little, call it like a little grenade, and we will squeeze it and then we'll let it go, and it will fill up with that bloody drainage, like it's a self-vacuum. This will come out the next morning after your surgery. Spine precautions. So for lumbar surgery, you'll be on spine precautions for a good 12 weeks. For cervical fusions, about 6 to 12 weeks, you'll be on pretty strict spine precautions. So we've talked about log rolling already. That log rolling is to minimize those lower back movements and putting strain on the upper chest. We want you to avoid sitting and standing for long periods of time like we discussed. No lifting anything heavy over your head. You can, reach your hand up into the cabinet to grab a coffee cup or something, but no heavy lifting over your head. No lifting more than 10 pounds, which is about a gallon of milk. No jerking, jarring type movements, no contact sports, no pushing or pulling. We kind of put these precautions under the BLTs, no bending, no lifting, and no twisting. SI joint fusion, you have a few other precautions for about 6 weeks. So we do want you to avoid those strenuous activities. Weight bearing is usually partial weight bearing, so about 50% on that operative side that we do surgery on. We typically like you to use crutches or a walker. We prefer a walker for about that first 6 weeks. We don't want you walking on uneven surfaces to avoid those trips and falls. We only want you to walk those short distances. So unlike the other surgeries, we want you to gradually build on that walking distance. If you're having an SI joint fusion, we want you to stick to just short distances each time you walk. We do want you to avoid going up and down stairs, sitting and standing for long periods of time, and lifting more than 10 pounds, and then squatting real deep. If you're sleeping on your side, we don't want you to sleep on the operative side that you had surgery on. And we do like a pillow between your knees. And we want you to avoid bringing one leg out too far from each other, so that abduction. So keep your legs pretty close to each other, like when you're getting out of the bed or the car or something. Physical therapy may begin day of your surgery, just depends on what time your surgery is. Physical therapy tends to work with you twice a day while you're here at the hospital. They focus on those big muscles of your body. So they're going to be getting you up, they're going to start walking you. You may need a rolling walker. They will definitely guide you if that's the case. And we don't want you walking more than 2 miles when you get home. So 1 mile is our goal, but no more than 2 miles within that first 6 weeks. They will practice stairs with you, those lower extremity exercises they'll be doing, and they're going to show you how to apply the braces if ordered and making sure you've got that good posture. The next screen is going to show you some braces that your doctor may use. The LSO brace is going to be more of the shorter brace, a lower profile brace, so for those lower lumbar surgeries. The TLSO brace will be for the upper lumbar surgeries. And then the quick draw will be used for lumbar surgery as well. Your surgeon may not use any of these braces, but these are the ones that you might see. And then the soft cervical collar, we do use that a lot for our cervical fusions. And let me talk a little bit more detail about the braces, because I didn't do that earlier. So the braces, if you are instructed to wear it, usually you wear it for about 3 months. It also depends on your surgeon. If you're having a cervical fusion, it could be just a couple weeks to up to 6 weeks that you'll be wearing that soft cervical collar. Occupational therapy, they typically will start seeing you on postoperative day number 1. They work with you once a day. They're going to focus on those activities of daily living, so bathing, dressing, hygiene. They focus on safety at home. They also are going to do some upper body extremity exercises, and they'll show you how to use some assistive devices. So Most people have seen this. This is called a long-handled reacher, so you can get things down low or up high, so you're not doing your bending. Long-handled shoehorn, so you can get your shoe on without bending over. Long-handled sponge, so you can get to your feet, get to your back. And this is called a sock aid. So you put your regular sock on. This will not work for those TED hose. So just a regular sock. And you can use the short socks as well, but stick one sock on at a time. You throw this down on the floor, you stick your foot in, and then you wiggle your sock on. And this helps you from not bending over to put your sock on. Occupational therapy will show you these assistive equipment. They unfortunately are not typically covered by insurance, so it's something you'd have to purchase out of pocket. But your coach will be able to help you with all these things as well if that's something you don't want to purchase. I do want to go over one other thing with you, and that was the incentive spirometer that I mentioned earlier. And what this is an assistive device to help take those good deep breaths so you don't get pneumonia after surgery. So when you do this, you put this piece in your mouth and you suck in like a big straw. You're going to watch two little chambers. This little chamber right here is the speed of your breath. So if you don't inhale fast enough, this little disc is going to stay at the bottom, and if you inhale too fast, it's going to shoot to the top. So you want it floating right between those two arrows. As you inhale, this big disc will raise up. This is how much volume you're bringing into your lungs. And it depends on your age and how tall you are, how much lung volume, how much lung capacity you have. Most people should be able to get up to at least 1,000. If you can get up higher, great. This is a little guide on telling us how high you've gotten. So let's say you have gotten to 1,500. We want you to do 10 of these every hour while awake. We want you to do 10 good ones. So if maybe on the third or fourth time you're struggling to get to 1,500 where you've been getting to it, that's your cue to stop and take a break, because it's not doing you any good if you're struggling to do it. As long as you do 10 throughout the hour, we are good with that. And you will use this for about 5 days at home until you're getting up and walking and moving around well at home. So this is the incentive spirometer. So we do have some other assistive devices. A lot of this stuff is for your bathroom. Now, a lot of this equipment, you won't need it for very long. So if you have any friends that you can borrow this equipment from, Goodwill is a good place to go. Amazon is also another place. So any resources you can use, definitely use those. But let me show you some of this stuff. So this is called a bedside commode, and this can be used in the bathroom, over your existing toilet. There's a bucket that goes in here, and you take the bucket out like it is now, put this over your existing toilet, and you've got the arm hand thing so you can help yourself up and off the toilet using that. This can also, of course, go beside your bed, but we don't recommend that because we encourage you to be getting up and walking to the bathroom. But also if you have a walk-in shower, this is nice. You can take the bucket out and set this in the shower so you have a place to sit in. So that is called the bedside commode. Also, you've got your shower chair. So we went over the shower bench earlier in the presentation, which is made for the tub shower, but this is made for more of like a walk-in shower. It comes with just a stool, and you can also get it with the back side like this is. But this, will give you that space to sit. So during that shower, if you can't stand for the entire shower, you've got a place to sit down. Also, they have grab bars for the tub or the shower, and you can look at getting those. And then they also have like a bed rail. So if you're having trouble log rolling to get out of bed, you can use that bed rail, and that will be an extra little support thing to pull you over. And then one other thing is the walker that you see on the slide. It has the wheels on the front and the stoppers on the back. Typically, we use those a lot for our lumbar fusion patients. And again, that's something that physical therapy will go over with you, and they'll make the recommendation if you need it or not. So we say call, don't fall. After surgery, you're at increased risk for falling because you've had anesthesia, you're on some pain medicine, you have IV in, you may have a drain, ice hooked up to you, and those compression devices. So what to expect? Bright yellow socks on, yellow armband, yellow magnet on the door. We could put your bed alarm on, and we'll be rounding on you on a regular basis. So expectations for you is please press your call light. We do not want you to get up by yourself. We'd rather come in every 30 minutes if that's needed to get up to the bathroom than you fall. So please don't be afraid to push the call button. So pain scale, we have you rate your pain on a 0 to 10 scale. 0 is no pain, 10 is the worst pain imaginable, 5 is right in the middle. So we'll ask you to rate your pain on that scale. For pain management, we have you on a multimodal pain management approach. What that is we use several different types of medication to help control your pain versus giving you a large narcotic like they did in the past. The multimodal pain management approach is also part of that ESR program that we follow. On occasion, your surgeon will still prescribe what they call a PCA pump. It's a patient-controlled analgesic pump, and it gives you permission to push that pain button, as needed, some IV pain medicine. It does have a lockout, so you can't, take too much of it, but we do ask that you are the only one who's allowed to push that button while you're on it. Usually it's just that first night after surgery, and then we're going to get you off of that and get you back to just oral pain medicine. You are going to experience a different kind of pain than you had before surgery. We do want you to intercept that pain before it gets severe, so don't be a hero. Take your pain medicine. If you are hurting, take it. If you wait too long, then you have to play catch up, and it's going to take half the day or all day to get you comfortable again. So that's why we say take your pain medicine on a regular basis. You'll know when it's time to start weaning down off of it, kind of spreading out, how often you take it. Let the nurse know if what we're giving you here at the hospital is not helping with that pain control. We can always call your surgeon and see if there's anything else we can give you. And then also make sure you ask questions to make sure you understand all the other pain management efforts we have in place. So cold therapy would be one of those things. And so for those of you having lumbar surgery, we use this cold therapy device. It's called a Polar Care. It's the one we currently use. And what this does is it fills up with ice and water while you're here at the hospital, and that ice cold water will circulate through this pad. And this pad will go on your back or on your side or on your front, wherever that incision may be, and that ice cold water will circulate through the pad. One thing with this is you want to make sure you put a barrier between this pad and your skin. You don't want this to go directly on your skin because it can cause a cold burn. You are allowed to take this home with you. So you will take this whole machine home with you, and you'll be able to use it at home. The first couple of days, we do like for you to wear it, pretty much as much as you want for the first couple of days. That is going to help with that initial pain and swelling after surgery. But then after that, try to stick with just 20 to 30 minutes every hour as needed for that pain and swelling. And we can show you, you and your coach, how to feel this while you're here at the hospital. If you're having a cervical fusion, you will have an ice pack like this. And this is already lined, and so we will put the ice in, and we can put that right directly on your skin. If you're having the posterior cervical fusion, we can use this ice pack, or we can use this one. It just depends on which one works better for you. Positioning also is another pain reliever. We say every hour, get up, move around, just to keep moving. Coughing and sneezing. If you have lumbar surgery, take that pillow and put it on your abdomen when you cough or sneeze, because you don't realize all those muscles that are attached, and that can cause that vibration and cause increased pain. Remember, we can't make the pain go completely away, but what we want to do is get that discomfort down so you can eat, sleep, work with therapy, and get home as soon as you can. Nerve pain may often persist or may persist after surgery due to manipulation of the nerve. So what happens is, let's say you're having all the issues down the right side. Well, you wake up from surgery, the right side feels great. Now it's the left side that's hurting. So what happens is when they move everything out of the way to clean up the bad side, now they've aggravated the nerves on the other side. So just know that those nerves are just aggravated. It will get better. There is some swelling that comes along with surgery. So once that swelling starts to subside, those nerves calm down, that pain should go away. Recovery also depends on how long those nerves have been compressed for. So if it's been several years, it may take longer for those nerves to plump back up. So your surgeon will typically be able to kind of give you a heads up on how those nerves looked after surgery. But immediately after surgery, you're going to have some relief of some sort as soon as you wake up. We do all we can to ensure your comfort and safety. So what that means is if you're super sleepy or if your blood pressure is too low, we will not be able to safely give you your pain medicine until you wake up somewhere. For medications at home, you will not get addicted to the pain medicine as long as you're taking them as prescribed. Taking them as prescribed means you're hurting. So if you're hurting, take your pain medicine. Being in unnecessary pain will actually stress your body, increase tense up those muscles and then slow down your healing. Also, you don't want to get up and move around, so then you put yourself at risk for getting a blood clot. You will be provided with the appropriate pain medicine, so please let your surgeon know if what we've been giving you here at the hospital has been working, or on the other hand, it has not been strong enough. We can see if there's something else we can give you for home. Do not take any other narcotic pain relievers other than what your surgeon prescribes you. Depending on your surgeon, they may let you take those NSAIDs, those anti-inflammatory medicines, after surgery in addition to your narcotic pain reliever. You do want to take a stool softener to help prevent constipation. A side effect of pain medicine is constipation. So if your surgeon does not send you home with any stool softener, you'll definitely want to take something at least twice a day at home for stool softener. Any equipment at home will determine that, and one of the pieces of equipment we typically can give you that is covered by insurance is that rolling walker. Have your ride available for discharge around lunchtime. Doesn't mean we're going to get you out of here right at lunch, but have someone ready on call to pick you up. Home health for physical or occupational therapy could be recommended by our therapist, and so if that's the case, our case manager will get that set up for you before you go home. It's typically not the norm. Most of our patients just go home, you do your exercises that are in your guidebook, and then after your follow-up appointment with your surgeon, they'll kind of determine if therapy is needed at that time. But sometimes our therapists want you to get a little extra something as soon as you leave the hospital. Your follow-up appointment will be 2 to 6 weeks after surgery. And also just know if you're a workers' comp case, everything has to go through that workers' comp case worker. So any equipment our case manager will let them know about, but it's the workers' comp case manager that will be in charge of getting all that equipment delivered to your house. So track your recovery. Pick one day each week to measure your progress. Don't look at each day and say you're not getting any better. You are. It just may be on a slower timetable than you desire. You are going to have some good days and bad days throughout your recovery. So just know that. The first day after surgery, I call that your honeymoon day. Sometimes you don't have as much pain that first day. It's that second and third day where you're going to have some more pain. So don't be alarmed if that happens. And then each week from there, you're going to feel a little bit better and a little bit better. And then that 4 to 6 week mark, that's kind of your peak of recovery. So that's where you're going to see the most noticeable results in the shortest time period. Just know you're still recovering, you're still healing after 6 weeks, but you should see a pretty good improvement at that 6 week mark. You want to resist the urge to hurry back to your usual activities. Protect that investment, follow your spine precautions to promote optimal healing. You don't want to smoke or chew tobacco as it will significantly slow down your healing. We have 2 awards here at the hospital. We have the Daisy Award and the Rose Award. The Daisy Award is for our nurses and the Rose Award is for everybody else in the hospital. So if you've had really great care, you want to recognize that staff member. We do have nomination forms we can give you here at the hospital. And then if you like to do stuff on the internet, you can go right to our website and nominate that staff member on the website. And every quarter we have a celebration. My Health One is a centralized location for your health information. It's kind of like the health portal you have at your primary care doctor's office. It, will give you lab results, some reports. It also does, some other functions, and you do create a username and a password for that. And we will give you information about that with your discharge instructions. Shared decision making. So that is saying this surgery is, jointly made by, you and the surgeon and your care team. And so if you have any questions throughout your hospital stay, definitely, let us know. How was your visit? Nowadays everything has a star rating. And so as a hospital, we also have a star rating. So we would love for you to share your experience with us. Google, Facebook, and Yelp are the 3 main places people tend to look. And then the last slide I have is thank you for watching this presentation. I am your care coordinator, so if you have any questions throughout your hospital stay, that's what I'm here for. So thank you for watching again, and have a great day.